Well, welcome to the ICBHPE Collaborators webinar series. This is our second webinar this year. Um, if you are new to the Collaborators group, if you haven't seen one of these webinars before, we are a group of educators from multiple different health professions from all over the world working to explore, critique, and advance competency-based education. My name is Ben Kinnear. I am a med-peds physician at University of Cincinnati and a member of the Collaborators group, and I'm going to be hosting today's webinar. Now, if you tuned into the last one, you know that this year we are going to lean into the idea of story or narrative in learning and thinking about competency-based education. What do I mean by story? Oh, first of all, if you don't know also, we do have a YouTube channel where you can find all of our past webinars. This webinar will be there as well. So we hope that you go check out some of the amazing previous presentations people have given. And then if you have to step away for any reason, you can catch today's presentation here after it's uploaded. So what is a story and how is it different than a didactic or any other kind of presentation we often do? Stories tend to have some unique features that don't always exist when we are sharing knowledge in other ways. Usually there is an element of time, whether that's actually moving forward through time or referring back and forth through time or even jumping around in time. There's some sort of causality where one thing causes another, causes another. That's kind of what makes a narrative flow. Often we try to draw meaning from stories. So it's not just giving facts, but it's drawing deeper meanings from it. There are events, and usually there's kind of a rise and fall in the tension that happens along the action. I think most people are familiar with that type of story curve that you see there. And then there's often characters. And these can be people, these can be places, these can be ideas. But characters play a role as the tension rises and falls. And stories have been used for sense making for a long time. And in many, many different cultures. They help us integrate different ideas and facts and emotions like cognition and affective processing, things that often don't play in the same sandbox get brought together through story. And they can be really powerful in us helping to make sense of the world and dealing with uncertainty and complexity. Stories are also really useful. We use them all the time in trying to remember things, recognize patterns, organize our experiences and our ideas, and even to transfer ideas across different contexts. We thought these would be really, really helpful in trying to share experiences, ideas, and sense making around competency-based health professions education. And so we have been looking for all types of different stories related to CBE, whether it's how it affected our identities or implementation in a given context, challenges, successes, all sorts of things. And today, we have an educator who has some really great stories to share. Some of the stories are his own. Some are stories of people that he has worked with and seen play out for him. And that is Dr. Matt Kelleher. So I want to pause and introduce him. Dr. Kelleher is an associate professor of internal medicine and pediatrics at the University of Cincinnati College of Medicine and at Cincinnati Children's Hospital Medical Center. He's an associate program director for internal medicine, where he leads initiatives relating to coaching and assessment. He also leads the first and second year medical student clinical skills course in the University of Cincinnati College of Medicine, where he teaches people about history taking, physical exam, and clinical reasoning. He does some really great work related to qualitative research, as well as integrating artificial intelligence into coaching and clinical reasoning. He is a really dedicated educator. And the reason I invited him on is because in recent years, he launched a competency-based education pathway within the University of Cincinnati College of Medicine. And it was really an organic kind of ground-up story. It was not something that was funded to a large degree. It was a story that was a grassroots effort by educators and learners, and he has some amazing stories to share related to that. So I want to welcome Dr. Kelleher, and I will turn the stage over to him to share his story.
Cool. Thank you, Ben. I'm going to see if the slides work. Yes, they do. Excellent. Okay. So I'm going to tell my story as Ben suggested. I have a few slides, obviously, but trying to really lean into the power of narrative here and story. So for the most part, I'm just going to talk and kind of tell you kind of how things have taken off. So when I finished residency 12 years ago, I took on a chief role at our residency. And in that chief role, I started working at the University of Cincinnati. And many of you are familiar with Ben, obviously, but also Eric Worm and Dan Schumacher. And the group in the University of Cincinnati is doing a lot in the GME world around competency-based medical education. And so for the first like 2 to 3 to 4 years of my like young career, I was living in this world all around CBME. Now, we were building a program of assessment and we were trying to develop coaching and learning all about validity evidence. And like it was a very exciting time, mapping things to EPAs and OPAs. And it was super exciting. And then I got a role at the medical school in 2018. And when I got the role at the medical school, it was to lead a course for clinical skills. And so naturally, as part of that, like it's teaching preclinical students like the fundamental of doctoring skills, those kinds of things. And as part of that, I got put on all of these committees, right? Curriculum committees and educational policy committees and things like that. And it was not long before I felt like I don't know if these slides are going to advance quickly, but like it felt like I was living almost in these two different worlds, like a double agent or something. Because all the time in the GME world, I was spending all this time talking about competency-based medical education and coaching and growth and development and things of that nature. And then all the time that I was at the UME world, we were talking about grading and policy and how do we make sure our students get the best residency selection possible. And it just felt like I was living between two different worlds. And it was a very like difficult place for me. It was confusing because I didn't feel like my worlds collided, if you will. And then COVID happened. And I don't know, I'm sure people remember, but when COVID happened, all of a sudden we were starting to like across the world, we were starting to talk about students graduating early, right? And we started talking about changes in assessment strategy. And all of this trickled down to the University of Cincinnati, where we started spending a lot of time talking about maybe we should go pass fail. And maybe we should think differently about the way we assess students. And there was just a lot of momentum and change happening at the medical school. Um, so all of that was an interesting time for me, and because of that, I think it led myself and several others to start asking some questions like, why couldn't we do something similar at the UME world? I think drawing on some inspiration from like, I don't know if people remember the Education for Pediatrics Across the Continuum, right? The EPAC, they were like starting to publish a lot of work around that time. And Ben was actually doing his work at the University of Cincinnati, his Macy's Scholars Project on time variable transition. And so I started asking the question, why couldn't we just actually graduate medical students early to transition into our GME programs that are already set up to do competency-based medical education? And so I put together a proposal and went to the medical school and asked them, could we do this? And as you might imagine, like as I went through all of the different stakeholders and all the different committees to say, hey, could we create a proposal or could we create a pathway for students to graduate early? The question that kept getting asked over and over is like, can we even make a defensible decision about our students' competency development to begin with? And so over the course of like a year, what was determined is that we probably needed to create a pathway first or a pilot proposal to even see if we can make a competency decision for our medical students at the University of Cincinnati. And so we put together a proposal. This is like 2021 to try to develop essentially CBME principles at the University of Cincinnati with a small group of students. Um, the idea was we weren't going to change the nature of the students' like curriculum. We were going to let them kind of continue along the same curriculum, but we were going to try to implement CBME principles for a group of students. And the students would apply to join that pathway. And we thought, it's relatively low risk for students. And, not surprising, many students were actually interested. They saw it, I think, in many ways as like an opportunity to try to like discriminate themselves or to get an opportunity to do something unique. And so we created a pathway for students to go through their clerkship year. The clerkship year where we are is the third year. So it's after they transition out of the classroom, they go into the year where they're doing all of their work in the clinical space for the first time. And they rotate through things like surgery and internal medicine and peds and psych. I'm sure it's similar across the world. But in that clerkship year, we wanted to create a CBME principles. So we thought we'll teach them about EPAs and we'll give them tools to gather feedback and we'll set them up with a coach and we'll create a dashboard so that they can see data and learning analytics and things like that. And what we did in that first year for that first proposal, what we learned was pretty obvious right off the bat, and that's that the students told us don't know if these slides are advancing or not, Ben. Um, what the students told us is that essentially, as long as they were being graded, it didn't really matter how much time we had spent on competency-based medical education or all these principles of competency development and growth, that they felt kind of pigeonholed, and they felt like the most important thing to them was impression management, and it was making sure they got a good grade, and that had kind of major impact on the way they interacted in the clinical environment. So we went back essentially and we asked the institution, and it's hard to kind of fully make this clear what it's like at the institution where, these would have been very different. So we asked them essentially, could we remove grades for a small group of students to create an actual CBME pathway and see what would happen to find out for the students? And to our surprise, that they essentially went along with it. If you want to hit next on the next slide there, Ben. They approved a pathway where we could actually put together a CBME pathway for students to go through the clerkship year without grades. And these are the changes that we made for students to actually try to see what competency-based medical education would be like for a clerkship student. So we mapped all of their assessments to the EPAs, and we created new tools for them to collect data. We created a dashboard so that they could see their data. We set them up with coaches for reflection, programmatic assessment, a competency committee, if you will, and we had to revamp essentially the medical student performance evaluation that would go to residency if we're going to be removing their grades and they're going to move towards more of a competency-based pathway. All the things that I'm sure everybody in this group talks about all the time around CBME. And since then, essentially, that's been 4 years ago now. And so what Ben had asked me to come talk about was essentially what we had learned, I think, and the stories that students have told us over these last 4 years. And I think if you want to go to the next slide, it's been interesting. I thought we were going to be redesigning assessment in many ways for these students. But after kind of living through this for 4 years with like these different students and different cohorts of students, I've heard like up close, like all of their stories, right? Like, and some of them are, messy and, their struggles and things like that. But it's been unique for me because for basically 4 straight years, 40 to 50 students, I've kind of had this like up close and personal view of their like lived experience going through the clerkship year under a new set of rules, right? Under a competency-based medical education paradigm, if you will. And so I thought it might be fun to just share some of the stories that we've heard, and then you can kind of draw your own reflections on what you think it means. A lot of them are the students' stories, so like there's sometimes they're more like snapshots, if you will, or anecdotes of things that they've told me. But I think, they're illustrative in their own way, if you will. So I'll start just by saying like the first thing I think over the 4 years, the first like set of stories or buckets of stories that I think we've heard most commonly is that students interact in the clinical learning environment completely differently. Many students have told me that kind of the same sentiment, like when the pressure of like exams and like scores are no longer the same, that they don't feel the same tension to kind of leave the clinical learning environment. They talk all the time about how so often students are kind of like trying to get home to study or they're trying to get to the coffee shop to study, and that the students in the CBME pathway with a new set of rules, right? Like they don't feel that same pressure to run to multiple choice questions or to UWorld or these kinds of things or Anki and flashcards, that they feel like they can stay in the clinical learning environment very differently. They talk often about like every interesting clinical opportunity for other students kind of comes with this trade-off, right? Of should they stay for that clinical opportunity or should they go home and study? One of my favorite stories is a student who told me one time they were in a grand rounds for, I think it was internal medicine or surgery. And I'm sure everyone is familiar with grand rounds, but big presentation, right? All the faculty physicians there, presentation. And they were sitting there in the grand rounds and they were from the CBME pathway, right? Where all of a sudden they have a kind of a different mindset around growth and development. And they were looking around at all of their classmates in the other pathways or the traditional pathway. And they noticed that they were the only one actually sitting there paying attention. All the other students were doing Anki flashcards or multiple choice questions on their phone while they were actually sitting there trying to pay attention and trying to learn. And for them, they were talking about how it's just an interesting experience, how it showed them that like their incentives had changed to some extent, where they felt like they could be more engaged in that learning opportunity. And the same thing for the clinical learning environment. I had another student who told me on our psychiatry clerkship, at our psychiatry clerkship, they have a pediatric emergency service shift that they have to go to, or a psychiatry emergency shift, I should say, where essentially they go and they see patients with decompensated mental health, right? Schizophrenia and things of that nature. And that shift is seen as it's not graded at our school. And so the traditional, I guess, culture is that the students kind of show up, they talk to their resident, and then they essentially get sent home. Sometimes they see a patient, but usually not. And this student talked about how basically, as part of the CBME pathway, they felt like a completely different incentive, right? So instead of like coming and leaving, they said, no, I actually want to stay for the entire shift. And the student said basically it was one of the best learning experiences of their entire clerkship year. They had like opportunity after opportunity to interview patients. They were kind of frequently given feedback, and it was this kind of like amazing learning experience that was incredibly formative. To the point actually that the student, in telling the story later, actually had decided to do, pediatric psychiatry as a result of this like learning experience and this shift. And they were just remarking and reflecting in themselves of like how it was different. Their entire incentive to stay for that shift felt very different versus the traditional students who tend to kind of like, if they're not graded, they have a very different incentive there. Um, Along those same lines, another one of my stories or favorite stories that I heard a student tell me one time is that they were on transplant surgery, kind of under this same idea of like, do I stay or do I not? And on transplant surgery, it's a busy rotation, obviously, long hours, and the shelf exam, the end of the clerkship exam that's counted as was coming up soon. And so everybody feels this pressure to study, right? And they had this opportunity where the patient they were caring for was going to get a new organ. And they had an opportunity to go with the transplant team several hours away to go get the organ, procure the organ, come back, actually transplant the organ. But they knew what that meant, right? That meant it was going to be long hours, right? They were going to be gone for a long time, essentially to go many hours to see this, come back for many hours, and that the entire experience was a difficult decision for them to make, but that they felt confident that in this pathway, they felt like they could make that decision, that even though they would have less time to study, that it would be worth the trade-off to go have this unique experience to learn from a transplant surgeon, and to have that experience. They later told me that, like the way that they told me in reflections was that, they felt like they were learning things that they would never learn, obviously, for multiple choice questions or flashcards, and that it was just a very different experience for them. Um,
Matt, can I jump in with one clarifying question and then one question that came up in the chat?
yeah.
The one clarifying question is you said that for this competency-based pathway, you removed grades. Can you describe what that means? Does that mean they're not assessed at all? Like, how can you make that clear? What does that mean and why it might change behavior like this?
Yes. Sorry if that wasn't clear. So the students are still assessed, and in fact, they're given lots of incentives to get more assessment data. It's just that the assessment data is not tied to a normative grade like honors, high pass, or pass. Instead, their clerkship, they're essentially given a, competency achieved based off the clerkship year or clerkship that they do, rather than getting a tiered grade. So they actually get more assessment data than I would say the average student because they're incentivized to pursue data. They're given new tools to go seek assessment data through like an app and QR codes, and they're incentivized to use the the evaluations for kind of everyone they work with rather than just one or two evaluators, which is more typical for a traditional student, where you might do 4 weeks of internal medicine, but just one person evaluates you. These students are trying to get an evaluation and trying to be assessed by everybody that they work with.
Okay, thanks for the clarification. And then um, Dr. Kavarzegi in the chat said, thanks for your thoughts. Do you think there might be a self-selection bias? In other words, that students who choose the competency-based pathway are the ones who otherwise would want these experiences anyways. And I think he typed that when you were sharing these incredible stories of people being more present and engaged in the learning environment rather than kind of skirting away to go study for a test.
Yes, 100%. There's no doubt about it. It's a self-selection bias. So the students apply. We actually even choose them, right? Because in many ways we're trying to find students who would be um, in alignment with this kind of learning. So there is definitely a selection bias for sure.
Ooh. And then Dr. Chan said, would love to understand more about the selection process. Interestingly, these students look relatively homogenous. Of course, I don't know what heterogeneity of the medical school is like. Um, so I wonder if you could comment on that before we jump into the next story.
Yeah, totally. So I don't know that I have specific data about diversity or demographics or things of that nature, but students essentially apply at the end of their second year to join the CBME pathway. Really, the only selection criteria we have is that we're trying to choose students who are essentially not trying to run away from grades, if you will. So students that are not just trying to not be graded, but that students who, just like Kelly asked, they actually align with this kind of learning, that they see the idea of growth and development as being valuable to them and the way that they would want to try to learn in the competency-based pathway. Um, we don't look at their grades. We don't look at their scores. The only other thing we do is we do think a little bit about the potential residency that they might want to choose. And that's mostly based off, advising from the student affairs department at our school. I think every school is probably a little different, but there are certain fields at our school that feel like the idea of going pass fail could be a risk to the student. And so the students often meet with student affairs. So you can imagine something like a surgical subfield, right, which might be really highly competitive. Sometimes they're advised that it's not wise to go through a pathway without grades if that's a field that they want to go into. And so those students usually kind of select themselves out, really, to be honest, just because they don't necessarily want to take that risk if there is a risk there.
And I don't want to I don't want to riff too much, but I can imagine if somebody sees a call for this pathway, if they've been harmed by assessment in the past, even if you are advertising it as, there's no more normative comparisons. If one of the goals is to be assessed more, I could imagine how somebody who comes from a marginalized background might say, I don't know about this. Certainly there is past trauma and harm might inform who decides they want to take a chance on this. I think in recent years, more and more students are familiar with the pathway, but especially when you started it, I think most students did not really understand what it was or what it would mean. I don't know if that's
100%.
fair to say.
That's very fair. Yes. I don't think
Yep.
any of us really knew what it would be like. It felt like high risk, I would say, when we started it 4 years ago. It doesn't feel like that same kind of risk anymore to students, I think. But 4 years ago, it definitely felt like high risk, mostly just because of the culture of our school.
Yep. And if it's okay, Matt, I know you have more stories you want to share, but I wanted to follow up. These questions are really great, and I kind of see it as setting the scene for the story that you're sharing. Somebody asked about how big the cohort is, and could you comment on the faculty development that was involved in making this pathway happen?
Yes. Faculty development is easy to comment on because there was very little of it. There's a group of us that like a steering committee, if you will. But if you mean by faculty development, like did we try to get to everybody who would be assessing the students? The answer is no. There's some faculty development for coaches that would meet with the students, but definitely no significant faculty development for all of the different assessors that the students would interact with over the course of the year. And then what was the other half of that question, Ben?
Size of the cohort.
Size of the cohort. So the cohorts have been relatively small. As Ben said, and I shouldn't say when we created this, I was kind of at the front of leading it, but I wasn't really receiving any protected time. This was essentially just something we thought was interesting and we thought would be, uh, I think, the right thing to do, if you will, or just at least like something good for our medical school. I remember pitching it at the beginning saying, like, even if this fails, if nothing else, it'll just put a spotlight on how we assess our students, make it a little bit more transparent to everybody. So when we started, it was relatively small. I would say we took 5 to 10 students, mostly just because I was worried about taking more. It's still pretty small. I would say somewhere between 10 to 20 students is usually, it depends to some extent on how many students apply. And this will be our fourth year or fifth year, I guess, running it here this coming year. So every year it seems to inch up slightly, but it's still relatively small.
Great questions. Thanks for answering. Thanks for putting those questions in the chat, and thanks for answering them, Matt. If people have other questions or comments, keep them coming. And Matt, if you still got it in you, by the way, I should mention Matt's sick today. He's actually home with influenza, but was still kind enough to visit to speak with us today. So Matt, I'll turn it back over to you for your next story.
Okay, cool. Do you want to move forward for me?
Yep.
So that's actually a good place to pause. So after I think like it became very apparent to us that the students were interacting with the clinical learning environment very differently. I think the other thing that we noticed is that students didn't seem to view assessment as a threat in the same way that they had before. In the traditional pathway, and even honestly, in that first attempt we had at trying to create a CBME pathway, because grades still existed, every assessment or evaluation was kind of like a kind of a quiet calculation, if you will, right in the mind of a student. Like if I ask this question, am I going to look dumb? If I try this and I get it wrong, was it going to hurt my evaluation? If I reveal this weakness, is it going to hurt my chances of getting honors? And so I think when assessment's tied to high stakes and to grades, obviously vulnerability feels dangerous, right? But when assessment becomes more developmental, which was hopefully what we were starting to see in the CBME pathway, something seemed to change. And students did seem to start acting and participating in the clinical learning environment differently. Two stories come to mind here that I think illustrate this. One of them was a student in the neuro clerkship who was telling me this story about a year ago, that when he started his neuro clerkship, that he started on a neuro consult service. And he talked about how starting right off the bat with neurology consults, he just came with, he decided essentially right from the beginning, I'm going to ask any question that comes to mind, and I'm going to try to take every opportunity I can possibly get. And I'm not going to worry about the consequences. I'm just going to put myself out there. And so he talks about the first day feeling like really nervous and anxious, but they're in the ICU, and he asked the attending for the very first patient, "Hey, can I do the exam, right, in front of the entire team? And can I try to explain everything to the family based off the plan and also the findings?" And he said, obviously it didn't go great. It wasn't perfect, right? He still needed a lot of guidance. But he talked about how it was like kind of an incredible opportunity for him because he learned a lot. The attending was more than willing to give him that time and to give him that opportunity. And what was more interesting is in the student's telling of the story is he described how like that mentality, and not just that one patient, but that mentality like that day and the next day, how it actually started to kind of trickle down and change the entire culture of the team. And he talked about how like it was almost like psychological safety had expanded, that like the residents started asking more questions, and the other students who were in the traditional pathway who were with him actually started to interact differently as well. They started to feel almost more empowered to themselves to take opportunities to try new things and to try things that maybe previously would have been seen as like a larger risk. And so the way he tells it is he talked about, that lack of fear that he felt around assessment in many ways kind of catalyzed learning for the entire team. But it's not always like that because like the other story that comes to mind in this area is there's another student who on their surgery rotation was telling me that they had learned pretty early in the year that the best way for them to learn, or the way they felt like they learned the best, was by being asked questions. They just felt like it was the most engaging. They felt like it helped them kind of process information, kept them engaged, and they enjoyed it the most. So when they were on their surgical rotation, they actually asked the attending, you know, ask me any question you have, right? Push me, challenge me, like, basically like give me your best shot, basically. And the student, in telling the story, talks about how it was like one of the richest learning experiences that they had ever had. That like they were asked all these questions, they were totally engaged in the operating room, um, but that it was actually the opposite from the other story. That the residents started to actually take this student aside after they would leave the operating room, and they started to tell them like, "What are you doing? Like you can't do this. Like you're not even getting like 50% of these questions right." like you're kind of like humiliating yourself basically, like and you're going to hurt yourself essentially by kind of publicly exposing constantly the fact that you don't know things. Um, and so the student just tells the story in essence, basically talking about how different it felt. I forget here. I want to capture this exactly the way she told me. But she talked about how, like, basically in the traditional kind of performance culture, being wrong was essentially still dangerous, right? But the striking part to her is that she realized, I think, that her entire mindset basically had shifted around assessment, and she hadn't seen it, didn't see it as a threat in that moment, and so as a result, she could kind of interact completely differently in the operating room. Um, in addition to like the idea of assessment no longer being feeling like a threat, one of the other things that I think we've noticed from students and stories we've heard is that their agency seems to change, or that they feel like they use their agency, I guess, in different ways is a better way to say it. Um, I think the clerkship year is kind of scary for all students. They want to look competent, they want to perform well. But the students in the competency-based pathway over the years have told me that essentially they feel, I guess, more empowered to pick up almost like a different set of patients, if you will, and to interact very differently. They talk all the time about how they're not afraid anymore to pick up the agitated patient in the emergency room who previously they might try to not pick up, right? Or the ICU patient, which is much more complex, or the patient with multiple comorbidities that might be very difficult to manage. They feel like as a result of the pathway, and I guess as a result of the threat of assessment not being the same, they feel like they can actually try to like pick up those more complex patients. This one student recently was telling me on their internal medicine rotation that basically the way this showed up for them is that they essentially started managing more patients. They were calling all their own consults. They took on way more responsibility, and they were basically talking themselves about how at the end of internal medicine, clerkship, they were managing five, six, seven patients at a time, which is much more in line with kind of like where we would expect students to be more into their like acting internships or in more advanced years. And they thought that all this was a result of essentially just being willing to step out and essentially use their agency to see more patients. Um, that agency, I think, also extends to the students in seeking feedback, which, I alluded to this, but this is like a large part of this pathway is the students do have to go. We ask them to go, pursue and seek feedback, if you will, or assessment data. We've changed some of the tools, but also we've tried to empower them to kind of capture some of that data themselves. And so I don't think no students, I would say over the 4 years, no students like seeking feedback. I think it's hard for all of them. And it's interesting because my feelings on this has changed, I feel like, over the 4 years. I think originally, if you'd asked me why students don't like to seek feedback, I would have said it probably had something to do with just not receiving, don't want to receive critical feedback. But I actually think it's different now. Like from hearing students recently, I think when they're in the clinical environment, and this is unique to clerkship students, but I think everything is focused on the patient. And I think stories I've heard from students over and over is that when they seek feedback, it almost feels like selfish to some extent because they feel like they're having to pull their resident or their supervising attending away from caring for the patient to give them individual feedback, right? Or to give them individual thoughts or to give them an individual observation. And I think, many of them talk about how that process is very difficult and they have to learn from it. One student, I want to capture her words like the way she told me, but she talked about this. The idea of seeking feedback was like one of the hardest parts for her in the clerkship year. Um, she talked about how like she actually dealt with like a lot of negativity and shame around like not seeking feedback, if you will, right? Like she described it as like having a internal scorecard where it was like, did I hit my goal or did I ask for enough feedback? And she said she used to set an alarm on her phone to try to remind her to ask for feedback. And I think she dealt with like a lot of like, uh, she was just really critical of herself when she did not actually do that. But she talked about the process of actually having to push herself to ask for feedback was over the course of the year something like a skill that she was able to learn. And as a result, she felt like it was really transformative was her own words essentially that she used. She began kind of learning so much more about how to seek feedback and how to navigate it. A lot of the students talk about learning to use the EPAs in and of themselves to try to target feedback, where they don't just ask for, can you give me feedback? It's now, hey, I'd like to get feedback on this specific EPA. And so they go into encounters asking things like, can you give me feedback on my clinical reasoning for this assessment and plan? Or, can you watch my abdominal exam on this patient or watch me counsel, with this patient? And they're trying to be intentional about the EPAs that they focus on. But I think that's been a challenge for all the students, and I think seeking feedback always will be for sure.
Matt, I wondered if I could jump in with a couple of questions.
Yeah.
One question is, I'll lead off, and then there's a couple in the chat. One, were there any stories of like negative experiences when seeking feedback, other than just it was hard to do? Because I know this has been a challenge in other CBE implementations of work compression making seeking feedback hard, or feeling like it's a burden on others. I think you kind of alluded to that a little bit. Or seeking feedback but not getting good feedback. Did any of that come through at all?
100%. Yeah. I don't think the students actually have told me over the years that like they definitely, it's not like they're getting great feedback always. That they're very aware that like some of the feedback they get is, vague and not specific. And but they still talk about how they've learned like tips, right? Like, hey, if I ask for feedback before I do something, I'm probably more likely to get better feedback, right? And different things that they have learned over time on how to do it. The other thing I think, Ben, to that point, that like it's not always just about the feedback. It's what the students tell me that they often say it's like the process of like saying, hey, I'm part of this pathway. I need to get feedback, that even if the feedback is not valuable, that oftentimes that leads to like a unique conversation or like an honest conversation. Some students talk about like it opens the door to new opportunity or new responsibilities or sometimes just like new learning, right? Like maybe it's not even specific feedback, but like it just opens the door to like a different conversation that they probably would not have had if they weren't honestly seeking feedback. So I don't know if that answers your question, but I don't think I think the students definitely still see it as something that's like challenging. And certainly you can see over the course of the year they get more comfortable with it. But I think all the students feel like it's hard to ask for feedback, which I think is like we've seen, across the literature.
And Dr. Chan asked a question about feedback as well, asking, were these learners more feedback seeking in comparison to the rest of the class? And then what did it look like for the faculty who were engaging with these students?
It's probably hard to say for sure that they're more feedback seeking, but my guess would be yes, my hypothesis, right? Like in many ways we are self-selecting students, right, who are probably more intrinsically motivated and driven to learn in this way. So I'm guessing that they probably are more open to seeking feedback, but they don't have any special skills. Like it's not like we chose students and that had already done this or were already good at this. They're all learning kind of at the same time. And what was the second part of that?
What did it look like for the faculty who were engaging with these students?
Yeah, so that's been interesting. One of the things the students, because it's a small cohort of students, they have to always introduce themselves as like a unique student, right? Hey, I'm part of a competency-based medical education pathway. As part of that pathway, I'm not graded in the traditional sense, but I do need to get, data and I need to get assessment and feedback so that I can, determine my competency development. And so they say that about the majority of the time, the students tell me the majority of the time that's met with a kind of like, oh, really, that's unique or that's interesting or boy, I wish I had that when I was in med school or something like that. And oftentimes it leads to a wonderful conversation. They still say there are still plenty of people, particularly in certain places, where that's kind of seen as like it's diminished, if you will, or it's seen as kind of like a why would you do that? Or a burden to them, right? Okay, now I have to do extra work for you versus, if I could just do the usual thing, which is grade you at the end of 4 weeks or something like that. So it's met with all different kinds of people and all different kinds of players, as you might imagine. The other thing that I should say about the pathway is we allow the residents to give students feedback and assessment data. the senior residents. Our school traditionally doesn't let the residents assess the students. It's just the faculty. So, this was actually one of the biggest changes for the students right from the beginning is now all of a sudden, all these people that they work even closer with could actually assess them and give them feedback. And so the students often talk about some of the best feedback and best assessment data they get is often from the senior resident who sees them more closely.
And then Dr. Ryan had a question, says, great to hear you talk about this, Matt. Do you think this is scalable, like to the entire medical school? And if not, why not? Is it resources, concern with the match, both?
Yes, I love that question. Can I tell my last set of stories to answer that question, Mike? Is that okay? I
I'm going
don't
to
know
say
if
yes on his behalf. It's
okay.
okay.
So Mike, thank you for asking that question because it sets up the last thing I want to say really fast. No. Um, so this is my last point, and I have a few stories to illustrate this point. But Ben and I have talked about this in our group. There's a few people helping to build this pathway together. And one of the most striking parts of this pathway isn't almost what the students experience like inside of the pathway, as much as I think it's like what they're witnessing outside of the pathway, if you will. The students, they all live with one another, right? They all study with one another. They're all rotating, right, with all of these students who are in the traditional pathway. And so they're all walking through the clerkship year together, just that the CBME students have like different goals and like almost like a different mindset. And I feel like that contrast in some ways probably has a large impact on the students' experiences inside the CBME pathway. I'll give you just a couple of stories, but like one story that a student told me is that they were talking about on surgery. I think it was pediatric surgery. They were rotating. It was a student from the CBME pathway with a student from the traditional pathway. And they were talking about how this student in the traditional pathway was like loving pediatric surgery. They loved the operations. They loved the attendings. They loved everything about it. Like to the point that this student was saying that the CBME student was saying from the outside looking in, this student looked like they were going to do pediatric surgery for a career, right? It was just like clear that they were absolutely loving it. And then they got one evaluation, or I don't even remember if it was an evaluation or like a piece of feedback that was kind of like, essentially not good, if you will. And they talked about how their like entire demeanor completely changed. They like no longer loved surgery, even though nothing had changed, right? The patients didn't change, the procedures didn't change, but all of a sudden that student was talking about watching their colleague, her entire sense of self almost change as a result of like one bad evaluation. And again, bringing it back to like the CBME student in watching that, like seeing that performance-based assessment and the harm that almost it can cause, almost like in some ways actually changes the way they see assessment themselves, I feel like. Another student told me also on surgery. There's a lot of stories from surgery I'm noticing, but like they were telling me how when they were on surgery, they noticed that in the morning they would all show up in the operating room and they would all look at the board of all the different procedures that were happening that day. And they talked about how the students in the traditional pathway, they would look at that board and they would spend, there was conversations that would happen outside of the process where they would all know the attending surgeons who were the easiest graders. And so the students would all sit there and they would meticulously map out how they could get the absolute most face time possible with the attending surgeons who would give the best grades. And this student in the CBME pathway was telling me this story because they were telling me how different it felt, right? Because these traditional students then are seeing basically all of the same procedures. Whereas from their perspective, they were going and looking at that board and looking at it completely differently, right? They were looking at the board to go, hey, where can I learn the most, right? Where are the complex patients going to be? Where are the potentially things that I have not seen yet or I need to learn? And how can I like make sure that I'm being, I'm mapping out my experiences to maximize my development rather than, grades. And again, the point is like they're constantly seeing their own experience, in relation to another. This other student told me about living with roommates, and he talked about every night that they would come home, and he would talk about his roommates on the traditional pathway. They would all talk about how like one bad interaction or the one missed deadline that they had, or one lukewarm evaluation, or a misstep in something that they had said that day, how it would like eat at them for days and for weeks. And like it was like they would talk about it constantly. Their moods would shift and their everything about it would shift. And it would lead to like a lot of anxiety and burnout, if you will, right? And the student telling me this story from the CBME perspective was saying it was just amazing to them how different it felt, that they didn't feel that same sense. They didn't feel that same sense of anxiety about every word or every misstep or every mistake that they might make in the clinical environment. Um, there's others. Well, let me just say this last one, and then I'll kind of give some closing thoughts. But like, you know, I think the other kind of in relation to one another comparison that the students in the CBME pathway talk about is they talk about how the students in the traditional pathway often describe feeling kind of invisible. Um, they're almost incentivized sometimes to feel like it's best to shadow or like blend in. And, the students in the CBME pathway talk about how it feels very different, that their entire incentive is not to blend in, it's to try to actually take every opportunity to do more. This one student was telling me on trauma surgery, they had two traumas come in at the same time. And so as a result, they just stepped up and basically said, "Hey, can I do the FAST exam, the ultrasound exam?" And to their surprise, the trauma surgeon basically said yes. And that led to essentially them doing the FAST ultrasound for every trauma from that point forward. Another student told me that they were on their, emergency medicine rotation, and they were reflecting back to me because they couldn't believe it themselves, but they were reflecting back that on one of their last shifts, just going up to the resident and saying something like, where was it? Basically saying like, "Hey, um, I'm going to go to this code stroke and see if I can help out. And then after that, I'll go grab the repairs and do that laceration repair for you." And it was like they were commenting on how different it felt, that they didn't feel that same sense of like just trying to kind of blend in and shadow, but that they actually felt valuable, like they could be and were incentivized in many ways to try to like take care of the patients and actually do more. Um, so I think like I think the clerkship here is not easy for anyone. Just like the closing, like the last few thoughts here, that like I don't think students, I don't think would say that the CBME pathway has removed stress by any means. They still work hard. I think the year is still hard. There's still, challenges for sure, but their focus is very different. And I think in the process of kind of constantly walking side by side with their peers in the traditional pathway, it almost has made the CBME benefits more clear. Things like the fact that they have EPAs to actually help them guide their learning, the fact that they have a coach, the fact that they have a dashboard to review their data and they can see it in real time. The fact that data points feel like low stakes and they feel like they have agency over the people that can evaluate them and seeking evaluations. It's like all of those benefits of CBME almost become clear, if you will, as a result of seeing students that are not in the pathway go through the same experience under kind of a different set of rules with a different mindset. And so I say all that, I guess, just to say to Mike's question, I think I've always felt like the goal should be to kind of scale this pathway fully. But sometimes I guess I kind of wonder, like, if if there's a world where maybe it actually is, maybe there is an advantage to some students saying, "Hey, I would like to do a CBME pathway," because I wonder if there are other students who might say, "I want grades, I need to be extrinsically motivated, or I don't know that I would learn that way." I don't know the answer to that. But I think it's been unique watching students constantly compare their experience by watching other students have a completely different experience.
I appreciate that, Matt. I know you've had some conversations about this idea of precision education. Is some of that the paradigm in which people trained? Is it competency-based education for everyone? Or, as you said, would some people thrive in the traditional paradigm? And is that even possible to have two happening at once? And what are the downsides of that?
Hmm.
Really interesting to think about. I was curious, Matt, if I could ask you, how have your thoughts about competency-based education changed? So you've started this pathway 4 or 5 years ago. You've got your own story happening behind the scenes about trying to explain this to leadership in a medical school, navigating challenges and pushback, navigating financial and resource restrictions. Like, has your thinking about competency-based education changed drastically during that time?
That's a good question. It's hard for me to remember. I feel like before we started this pathway, I don't know that I fully, if you had asked me, I feel like I don't know that I would have fully completely understood what CBME is. I think as a result of trying to implement it and learn, I feel like I've learned a ton about it. So I think probably some of the things that have really changed drastically for me would be this idea of like, are there certain learners who actually might benefit from a different paradigm or a different idea of training? I don't know the answer to that, and I'm not really prepared to say the answer is yes or no to that, but it has made me wonder, I guess, if some students benefit more from extrinsic motivators and things like that. But I don't know, Ben. I guess I'm rambling. I'm not sure exactly how my thoughts have changed. They've definitely evolved. I think if you had asked me 4 years ago what CBME meant, I would have given you some answer mostly around assessment. And I think now, if you ask me, it's much more about a way of kind of like learning and a way of interacting in the clinical environment and a way of seeing yourself around growth and development. And so to me, that's been probably the biggest shift is just watching people realize it's not about a data point, it's not about an EPA, it's about just a total mindset shift in the way one orients themselves around learning and growth and trying to be the best they can be personally.
I love it. I know we have just a couple minutes, so I'm going to try to add this question in from the chat. Can you say a few words about the competency committee process, frequency of review based on EPAs or something else, adequacy of data, etc.?
Yeah, I can. And this process also has evolved over time, but let me know if you want other details. But it's a group of probably 10 to 12 educators. Everybody is volunteering their own time. We review the students' data ideally 3 times a year. Sometimes it's just twice a year, but ideally 3 times a year. We have some dashboards that we show the data where we look at both the quantitative data as it's mapped to the EPAs and the narrative data. What we have landed on in our most recent process is that the people in the entrustment committee try to review the data ahead of time. They try to put in ratings for how they think the student is doing. And that's mostly just based on, do we think the student still needs direct supervision, or do we think that they could do that skill with indirect supervision? Things like gathering a history or doing a physical exam. Um, and then we come together, we review the data, we discuss people's ratings before the meeting, and then we make another rating at the end of that meeting. And that process has evolved. I think we've gotten better. We've learned more. It's still not perfect, for sure. And we don't do all the EPAs. I guess I should say that. There are 13 EPAs that the AAMC has for medical school, but we've focused on, I think, 7 of them, which the literature has talked about are most observable in the kind of the clerkship year. So we don't try to do all of the EPAs either. We just focus on the ones that are most observable.
All right. Well, we're coming up on time. Matt, I just want to say thanks again for sharing your story, sharing your experiences. I have Matt's email up on the screen. So if people have other questions about the pathway specifically, or want to hear other stories or learn more with him, feel free to reach out to him. Again, thanks for sharing all these experiences. And if you're watching this and you have a great story that you'd like to share relating to competency-based education, or you know somebody who has a great story, please send them our way. We want to share as many stories as we can from as many different viewpoints as we can and as many places around the world. Again, we're looking for transformation stories, implementation stories, struggle, or frankly, stories that are just fun. Please send them our way, and we'd like to have you on the webinar. Thanks again, everybody. Have a wonderful afternoon or evening or morning, depending on where you are. And we'll see you next time.